it starts with the inspection, then palpation, and the last part is auscultation. There is not much to be done in the examination of precordium. There are just few points that you need to remember while you are performing the examination of precordium. Again, it starts with the introduction. अस्सलाम वालेकुम, मेरा नाम डॉक्टर मोहम्मद ज़मान है और मुझे आपके सीने का मुआयना करना है। उम्मीद है आप इसके दौरान ताउन करेंगे और इससे आपको कोई तकलीफ़ नहीं होगी। And then you have to examine the precordium while you are standing on the side. बाज़ औक़ात ये होता है कि examiner is standing on the other side, पेशेंट की एपेक्स बीट डिस्प्लेस्ड होती है इनटू द एंटीरियर एक्सिलरी लाइन और मिड एक्सिलरी लाइन। आपको यहाँ से एपेक्स बीट नज़र नहीं आ रही होती, लेकिन एग्जामिनर चूँकि वहाँ पे खड़ा है तो उसको वहाँ पे एपेक्स बीट नज़र आ रही होती है। सो इट्स वेरी इंपॉर्टेंट वन, आप थोड़ा सा आगे झुक के ज़रूर देखें एक्सिला की तरफ। अनदर वे इज़ ऑब्वियसली व्हेन यू गो एट द फुट एंड यू आर इन अ बेटर पोजीशन टू लुक फॉर एनी विजिबल पल्सेशंस। सो उसको देखिए, opposite side पे देखें, any visible pulsations. Same, the part of inspection is to look for any pulsations in the neck. If you find any pulsations in the neck, you need to decide whether these are arterial pulsations or venous pulsations. And if these are venous pulsations, the pulsations of the internal jugular vein, then you have to measure the JVP in a patient. We'll discuss briefly. You need to go at the foot end, see for any chest deformity, any bulge like in congenital heart diseases. If there is cardiomegaly in early stages of development, there may be a bulge on the precordium. And you also look for any visible pulsations that may not be visible while you are standing on the left side of the patient, right side of the patient. Look for any epigastric pulsations as well. And then you start with the palpation. आपको कहीं पे दर्द तो नहीं है सीने में? You need to localize the apex beat. आप वैसे अगर आपको visible pulsations नज़र आ रही हैं तो straight away go to that area. Obviously जहाँ visible है वहीं पे palpable भी most likely होंगे. अगर आपको visible pulsations नहीं नज़र आएँ तो periphery से शुरू हों और midline की तरफ आएँ। वैसे as a rule आपको बताऊँ, जितनी gentle आपकी palpation होगी उतना ज़्यादा likely है कि you will feel something. Sometimes you just place your hand, you get the apical pulsations as well as sometimes thrill is also palpable. So this is your best chance when you start palpation of the precordium to identify these findings. आपके लिए short case जो exam के अंदर रखा होगा most likely, if we get a good case, we'll prefer that there is a case of say mitral regurgitation, because in case of mitral regurgitation there are a number of findings. Apex beat is displaced, there is a pansystolic murmur at the mitral area, and we just want to test what is your approach towards the patient. We might get a case of aortic stenosis or a case of aortic regurgitation, and one case which we all like in the medicine department is the case of mitral stenosis. So these are the common cases that we get across in the clinical practice, और यही हम आपके short के वहाँ पे generally हम रखते हैं. So in case of mitral regurgitation, for example, you might get a thrill and a displaced heaving apex beat. So once you identify the apex beat, you need to describe the apex beat in terms of its location. किस intercostal space के अंदर है और what is its correlation with the mid clavicular line. You need not to measure it, you can just say the apex beat is just lateral to the mid clavicular line or medial to the mid clavicular line, or it may be in the anterior axillary line. You can use these anatomical landmarks, anterior axillary line or mid axillary line, or if it's somewhere between mid clavicular and anterior axillary line, you can say apex beat is midway between the anterior axillary and mid clavicular line. So one thing is the location of the apex beat. The second thing you need to tell about apex beat is what is the character of the apex beat. Is it just strikes, which is a normal apex beat, or is your finger lifted above the level of the chest, which is called heave. Heave ट्रेडिशनल ओल्ड इंग्लिश का लफ्ज़ है जिसका मतलब है उठाना, टू लिफ्ट समथिंग. सो हीव इज़ व्हेन योर फिंगर इज़ लिफ्टेड अबव द सरफेस, दिस इज़ हीव. और इट्स जस्ट लाइक somebody is knocking against your finger, which is called tap. Now tap is, what is a tap? It's a very crispy sensation, something just like tapping under your finger. It's a loud hard sound. So अगर आप apex के ऊपर देख रहे हैं तो it is a loud first hard sound which is so much loud that it is palpable. I mean your finger can hear this sound. इसी तरह से the tap may be palpable when you are palpating the base of the heart. And when we say base of the heart, we mean the larger vessels, which is the pulmonary area and the aortic area. Again, sometimes the questions in the exams are very easy, like what is the mitral area, what is the tricuspid area, what is the pulmonary area, aortic A1 and A2 areas. Now the mitral area is the area of the apex beat. So जहाँ आपको apex beat मिली उसी के अंदर you have mitral area. Where is the area of tricuspid valve? Remember that these areas do not correspond to actual anatomical location of these valves. These are the areas where a murmur of this valve would be heard best. I mean apex का मतलब ये नहीं है कि यहाँ पे actual mitral valve पड़ा हुआ है, मगर mitral valve की जब भी abnormality होगी तो this is the area where you will hear the murmur best. Tricuspid area is along the left parasternal border. In normal individuals, it's in the 4th or 5th intercostal space. If heart is dilated, cardiomegaly है, तो generally जिस intercostal space के अंदर mitral valve होता है, उसी या उससे एक intercostal space above you get a tricuspid valve. But in normal individuals, it's usually in the left 4th or 5th intercostal space. Pulmonary area is in left 2nd intercostal space, and the A1 area is in the right intercostal space along the parasternal border, and A2 area is just below the pulmonary area, that is the 3rd intercostal space on the left side. Sometimes the command is just to examine the precordium, but some candidates do get this command of examine the base of the heart. Or like in yesteryears, we have seen examiners asking candidate to auscultate a particular area, like auscultate the pulmonary area of this patient. So you need to follow the whole protocol जिस पे हम बात करेंगे. So if you find apex beat, first identify the intercostal space. Now the idea of identifying the intercostal space is you start with the suprasternal notch, you go down, you identify the angle of Lewis, and you have to do these steps. And just lateral to the angle of Lewis, adjacent to angle of Lewis, is the 2nd intercostal space, 3rd, 4th and 5th intercostal space. Suppose this is the in this horizontal axis the apex beat is in 5th intercostal space. But what is its relation with the mid-clavicular line? You need to place your fingers as if you are identifying the medial and lateral end of the clavicles. Arbitrary line drawn from this mid-clavicular point, and then you see its correlation with the relation with the apex beat. So suppose in this case apex beat is in left 5th intercostal space medial to the mid-clavicular line. If you are unable to identify the apex beat in this position, the next step is do not spend much of your time if you are not able to identify the apex beat. The next step would be to ask the patient to turn to the left side. ठीक है, उस तरफ थोड़ी करवट ले लें और आप इससे आइडेंटिफाई करने की कोशिश करें. Just in case you're still not able to identify the apex beat, what is the next step? You ask the patient to lean forward, और उसके अंदर आप apex beat ठीक है सीधे होकर लेट जाइए. The leaning forward position के अंदर No, the step 1 was in this position you identify the apex beat, नहीं मिली लेफ्ट लेटरल में ले जाएं, नहीं मिली लीनिंग फॉरवर्ड के अंदर ले जाएं. अब ये after step 3 you are not able to identify the apex beat. What is the step 4? Look for dextrocardia. किसने किया था मेरे साथ उस दिन डेक्स्ट्रोकार्डिया का केस? आई थिंक अरीब था. So he is not here, and I am glad he was able to identify. मैंने उसे एक short case दिया था, which was a case of dextrocardia, and he was able to identify it as a case of dextrocardia. So there, the apex beat was palpable on the right side. So there may be dextrocardia. I mean, if I have to select your short cases, most likely I would not select a case of dextrocardia for you, but you should keep in mind there may be a case of dextrocardia as well. So look for the dextrocardia on the right side. And if you are still unable to find the apex beat, it's not your fault. I mean, don't feel guilty that I was not able to. Okay, just say straight away apex beat is not palpable, because apex beat may not be palpable if there is thick chest wall, if there is emphysema, the distance of the chest wall and the heart is increased, there is a mass in between. Even in normal individuals, sometimes apex beat may not be palpable, or if you are obviously inexperienced, but at this level it's acceptable. So again, coming back to the apex beat, you need, first of all you tell the location of the apex beat. The next thing you need to identify is the character of the apex beat. Is it normal? Is it tapping? Is it heaving? And heave can be ill-sustained, well-sustained heave. The well-sustained heave is that is there for more than 2/3 of the duration of systole. It's well-sustained heave. We'll discuss what are the causes of ill-sustained and well-sustained heave. Then the third thing you need to tell about is it localized or is it diffuse? Like localized apex beat is if the diameter of the apex beat or point of maximum impulse is more than it's up to 2 centimeter. अगर 2 सेंटीमीटर से ज़्यादा एरिया के अंदर आपको एपेक्स बीट मिल रही है, दिस इज कॉल्ड डिफ्यूज एपेक्स बीट. And one of the reasons may be a dilated heart. In case of dilated heart, you may get apical pulsation in a larger area. If there is an aneurysm, it may be dyskinetic type of apex beat. So after and apex beat is generally, is it systolic or diastolic? Apex beat सिस्टली में आती है, ओके, बट सिस्टली में एपेक्स बीट तो तब आएगी जब हार्ट चेस्ट वॉल के ज़्यादा करीब आएगा. तो सिस्टली में तो हार्ट कॉन्ट्रैक्ट करे तो पीछे नहीं जाएगा. फिर कब आनी चाहिए एपेक्स बीट? डायस्टली में आनी चाहिए, लेकिन आती नहीं है, आती सिस्टली में है. इसकी क्या रीज़न है? Yeah, the reason is that arrangement of the cardiac muscles is it's spiral. It's in shape of 8. So it's, imagine this is the left ventricle, and when it contracts, the actual apex of the heart goes down, but area just above the apex of the left ventricle, it gets closer to the chest wall. It moves like this. So the apex beat does not correspond to the actual apex of the heart. It's an area just above the apex of the heart that gets closer to the chest wall, and it is palpable. Is there a condition in which you might get diastolic apex beat? It's I mean kind of a bit advanced question. Okay, you go and read about is there a condition in which you might get a diastolic apex beat. You may get double apex beat in a case of hypertrophic obstructive cardiomyopathy. So after identifying the apex beat, and obviously when you are palpating for the apex beat, you might feel a thrill. A thrill is actually a palpable murmur. कितने लोगों ने देखी हुई है, palpate की है thrill? सिर्फ एक हाथ, 2 हाथ, 3, 4, 5, 6, इस साइड पे अच्छा यहाँ पे भी है. सो देयर आर फ्यू पीपल हु हैव. कहाँ मिलेगी आपको ये थ्रिल? मेरा मतलब है ये थ्रिल वाला पेशेंट कहाँ मिलेगा आपको? जिन लोगों ने नहीं देखी उनके पास कार्डियक सर्जरी। वैसे मैं आपको एक सजेशन दूँ, यू कैन गो टू 2 institutions. One is the Gulab Devi Hospital and other is Punjab Institute of Cardiology. They have multi-story dedicated centers for these valvular heart disease and congenital heart diseases, and every second patient is where you will find a thrill. I mean, when I was, it's not something odd. When I was in final year, I and my friend, we used to go to Punjab Institute of Cardiology, and what we would do is I would examine the patient and my colleague will study the echocardiographic report, and I will tell him the findings and he will tell me whether my diagnosis is correct or not. So the only way to be perfect in the cardiovascular examination is obviously to examine the patient, to identify the findings, to correlate them and to make a diagnosis. And let me tell you, in medicine there is no alternative of the experience and the effort you put into it. So you have a few days, I mean you can at least spare 2 to 3 hours and just go and see a few cases of precordial examination. Then after identifying the apical area, then you also palpate other areas of the heart. If I place my hand like this, I am palpating the tricuspid area, the A2 area and pulmonary area. And then I can place my hand in this direction, and now I am palpating for the base of the heart, that includes pulmonary area and aortic area. Sometimes, especially in a CVS case that you might get in the exams, patient may be having pulmonary hypertension, and in case of pulmonary hypertension, P2 is loud and that may be palpable. So always look for a palpable P2. और कैसी होगी palpable P2? It's just like a tap. Someone is tapping under your fingers. Then the next step is to place your hand like this and look for parasternal heave. It's a left parasternal heave because it's detected along the left parasternal border, but it's actually a right ventricular heave. It's seen in cases of, right, just like apical heave is palpable in cases of left ventricular enlargement or left ventricular hypertrophy, and parasternal heave is palpable in cases of right ventricular hypertrophy. आपको ये कैसे पता चलेगा कि जो आपका थंब मूव कर रहा है ये रेस्पिरेशन की वजह से मूव कर रहा है या हाइपरट्रॉफी की वजह से मूव कर रहा है? One is obviously the respiratory rate is like 20 per minute and the cardiac rate is like 70 per minute, so obviously it's more frequent. If you are still confused, you can ask the patient to hold the breath, and if you still get these movements, upward movement, this is a right parasternal heave. Similarly, you can palpate in the epigastric region. When there is right ventricular hypertrophy, you might get the epigastric pulsations as well.